We're going to raise the house lights here for this next phase, which is question and answer, which is wonderful. I don't think there's any need for people to leave their seats. I think Mr. Locey can handle just raising their hands and calling upon people. The comment period will ask people to come up, but without elimination, I'll just turn it back to you, and I think that's a great way to handle this. Please proceed.
Hey, under Plan B, prescriptions, the way I understand it, are parked away from a regular insurance. It's a standalone type of program, not subject to the deductibles and co-insurance maximum.
That's correct.
So, you know, you could incur thousands of dollars worth of prescription expenses and never meet any out-of-pocket maximum. Is that correct?
Thousands is probably an overstatement.
Are there prescriptions that are not covered under your 3 tiers?
No, all legend drugs, federally approved pharmaceuticals are covered. It's not a closed formulary. It's the same exact formulary, if you will, the same list of drugs that you currently have under Consortium across the shield. There's no differences between that coverage. Under both plans, anything subject to a copay, so even your mail order copay under Plan A, if you will, that doesn't go towards your out-of-pocket maximum either. The copays under both retail and mail order under the Plan B also do not roll up to the out-of-pocket maximum, so that is true. In terms of impact, here's what I can tell you. Now again, everybody's different. So I'm not going to sit here and tell you that I'm going to tell you exactly how much you're going to spend. What I can tell you is how much the average person in terms of prescription drugs spends in this particular consortium. On a monthly basis, the average contract has 3 prescriptions filled a month. The average covered life has a little over 1 prescription filled per month. Now, of course, as we get older, I'm on 2, other people may be on 3 or 4, some people may be on none. So again, the impact of this particular program is going to be different for everybody. What we have to do is, from a consulting perspective, an actual perspective, a rating perspective, is we have to look at the benefit plan design between both programs, the level of benefit you get, and then see what the average utilization would be, capturing both outliers on the low end and the high end, and come up with a premium differential for that level of coverage. That's what we've done. So, in terms of impact, you know, it's going to vary from person to person. And again, I personally don't think it's going to be thousands, but yes, we're going to pay more in terms of prescription drug copay under this program. Could it be several $100? Yeah, it could be. Could it be none? Yeah, we don't have any drugs enough. So, I mean, there's certainly a variance in the impact that's going to have. But you're right. It does not accumulate towards the out-of-pocket maximum. Only the 20% co-insurance for those handful of items that we went through accumulate to the out-of-pocket maximum. Yes.
We're very efficient. The 95% of the expenses of the consortium goes back to pay with the drugs. So if we're going to save 18%, aren't we just shifting that over so that we're going to pay 18% more for our medication?
Some of it is certainly cost shifting. There's no question about it. All of it is not cost shifting. Most of it is. Some of it does come from people starting to ask questions. For instance, on the drug side, just to give you an example. On the medical side, it's really just straight cost shifting. I mean, you talk about higher deductible, a higher out-of-pocket max, people are going to pay a little bit more out-of-pocket, no question. On the drug side, there's really 2 elements involved in driving down the cost. One is, yes, cost shifting. You're going to pay more for it. The second part is trying to drive better consumers. And basically what that does, because you're paying a little more out of pocket, you're strongly encouraged to have some communications with your physician. In many cases, and you can go through the list yourself, I don't have the list in front of me, but you can go through the list of medications, and they're usually classified by disease category, if you will. So if you've got heartburn, you can look up those drugs. If you have high blood pressure, you can look up those drugs. But there's a litany of drugs available in a lot of different classes to treat a lot of different illnesses and injuries. Just to give you an example, for people who suffer from acid reflux or the heartburn, there's things that range from Nexium, which is the new purple pill, which is a brand name drug, all the way down to omeprazole, which is a generic drug, and then there's everything in between. You can Pralisec over the counter, you can Pralisec behind the counter, and it all varies in cost. What a lot of these plans try to do, other than just is try to engage the patient in the conversations with their physician. So that they do have an educated discussion about what do I need, how much does it cost, and how much am I going to spend out of my pocket to get it. Because at that point, you're trying to educate the consumer, you're trying to get them to make a more informed decision about what they're purchasing. Does it take raising the copay to do that in a lot of cases? Yeah, it does. Studies will tell us that the required differential between the tiers of drugs to get people to ask questions is around $15. So that tells us what drives the consumer. There's a lot of studies out there. You can look them up yourself. There's a lot of studies out there on the subject in terms of consumer-driven health plans, driving consumers to better purchasing of medical services and prescription drugs. This is certainly an area that's seen some great growth over the last 20 years. I remember when I started in this business, drug didn't even account for 10% of the drug or the cost of claims spent. Now it's around and over 30% in a lot of cases. So it's been a big growth area in terms of expense. So yeah, a lot of insurance plans, a lot of employers have cost shifted, but they've also cost shifted with the intent of trying to engage the consumer a little bit more effectively. But yeah, you're right. I mean, it is, you're going to pay more out of your pocket. There's a variance in premium, so you get the break on the premium. So there is a trade-off, there's no question about it.
Correct me if I'm wrong, but if the co-insurance is in addition to the deductible,
It is.
that's kind of like 20-50.
Yeah, it's the same as it is now. The deductible stands alone, then the out-of-pocket maximum is the 20% up to that cap. So you have to add the deductible to the out-of-pocket maximum to get your maximum exposure, sans the prescription drug copays. So the prescription drug copays would be on top of that. Now, just to give you some background information, even under the current plan, $400 out-of-pocket maximum, because there's so few benefits exposed to it, not everybody meets their out-of-pocket maximum. Most people will meet the $50 deductible. You only have to go to the office once to get a $50 deductible.
Basically, 5.5.
That's our for family.
That's the 125 is on top of the 400.
That's correct.
Okay. Now, and again, correct me if I'm wrong. Previously, the previous policy we had up until this recent consortium, wasn't that part of the 400?
No. I've been involved in this consortium for a long time. And I believe that the way it was under Phoenix Mutual as well. I'd have to look, but that part of the program hasn't changed one iota since at least the early 80s.
I had never seen the 525 including the medications that allow something. I never realized that was 25.
Yeah, it's always been that way. The deductible stands alone, and then the out-of-pocket maximum is just the accumulation of the 20%.
Now, are you saying we continue after the out-of-pocket and pay 20% on medication?
No. No, under the Plan A, when you meet the out-of-pocket maximum, with the co-insurance, 20%, that stops and it reverts to 100% back. The mail order co-payment of $8 doesn't accumulate to the out-of-pocket maximum, you would continue to pay that. So, if it's a co-payment, it doesn't accumulate to the out-of-pocket maximum. If it's a co-insurance, the 20% it does. No, that list is a list of most commonly used drugs. If you go on the Blue Cross Blue Shield website, and I don't have the website name, I think it's accelerpcbs.com, which can certainly, I'm sure the district has developed. If you go on their website, you can electronically get their entire drug listing by just putting in, doing a search. But that's only a truncated list for publishing purposes. It's not a complete list of drugs. It's the same, and again, I can't iterate this enough, it's the same under both programs. There's no difference in what drugs are covered under the two plans. The only difference is how much you pay for those drugs at the point of sale.
So, if I'm understanding this correctly, a family plan would go go from a deductible of $125 to $750. Additionally, the medications now, not up in the mail order, but we can go to your local drugstore. The medications now under the new plan don't even count towards the deductible. So it's on top of all of that. So it's a lot more.
It depends on the way you use the program.
Well,
Again, most people don't meet the $400
just a minute, just let me finish. One thing for sure, we're all going to get old, God willing, and we're going to have to take medicines. So the difference between paying 20% now that goes to our deductible as opposed to worst case scenario, $30 for my copay, which doesn't even go to my deductible,
Well, neither goes to
can become
let me
significant.
clarify one thing. Neither goes to deductible. Deductible is separate from co-insurance maximum.
No, I'm saying if I pay 20% for a medicine now,
Right.
that 20%
Goes
is
to
going
out-of-pocket
towards
maximum.
my,
Out-of-pocket maximum, now you're deductible.
that doesn't go to the deductible, but it goes to the out-of-pocket.
Maximum, yes.
But these new insurances don't go.
That's correct. Yes.
I just see my name here, it says out-of-pocket maximum, plan B, it says not adequate. Up here at the board, it says $550.
For a drug, again, that's just the drug sheet.
Out-of-pocket maximum.
Right, that is just for prescription drugs.
Okay.
There's no out-of-pocket maximum on the drug. You pay the copay. There's no capping mechanism in the prescription drug program for the amended plan for prescription drugs. Wait a minute.
Can you explain the therapy for the drugs?
For certain medications, there's a limited list. I don't know if that list was also included in some of the handouts, but there, if you go on the Blue Cross Blue Shield website, there's a limited number of prescriptions that may require people to go through what they call steps. For instance, I'll use, I'm trying to think of a drug off the top of my head if I can. Well, anyways, there's certain drugs that may have, or certain conditions that may have, again, a number of therapies available. Some are very low cost, some higher cost. Some medications may, or some particular medications may have a requirement that you try the lower cost ones. If they prove ineffective, then you can move up the chain. There's definitions certainly available on Blue Cross Blue Shield's website about it. It's a limited number of drugs, it's not all drugs. It's only those drugs with a number of therapy alternatives within their class. But yes, there is a requirement in some cases that you may have to go through either step therapy. There's also a requirement in some cases that you may have to get a drug prior approved. So you have to have your doctor send a letter in to Blue Cross Blue Shield showing that it's medically necessary for treatment of your illness or injury, and they'll go through the process and cover it. But there's a listing, again, on the website. It's a limited number. It's only a 2 or 3 page document with the listing of the drugs. I don't have it available for me today, but certainly as you start to discuss this more, get into more detail about it, if you seriously consider the 2 plan designs, you want to look at that type of detail, that's certainly available. We can certainly get more information out about that. We didn't want to, drag this down into some of the minutiae, if you will, in terms of data and some of the other things. We want to try to keep it fairly high level to make sure everybody has at least a base understanding of the differences between the 2 programs tonight. Certainly when it gets to further investigation and discussion, whether it's the collective bargaining table or other arenas, there'll be a lot more detail to be presented and a lot more information for everybody to go through.
Are you familiar with the night shift plan?
Sure.
Can you tell me if plan B is the least equivalent to that plan?
I can tell you that it is at least equivalent to that plan.
Can you repeat what you said?
He asked if I'm familiar with the night shift. It's referred to as the New York State Health Insurance Plan, sometimes referred to as the Empire Plan. Basically, it's a a program. It's the largest program in New York State for public employees to participate in. Basically, any municipality in New York State can participate in it, in the program. And the question was, is the night shift plan, or I'm sorry, is the amended plan at least equivalent to the night shift plan, if I frame that properly? And my answer to him was, yes, it's at least equivalent to, certainly in my opinion, it's substantially better than the night shift plan. The night shift plan has a lot of additional co-pays in other areas, other requirements, prescription drug co-pays, etc. That are a bit higher than this program that we're looking at tonight in terms of the amended plan. So in my opinion, I didn't have a side-by-side for you tonight on it. Certainly something we could provide, but in my opinion, this amended plan is substantially better than that night shift program.
And the state plans, pretty much all of them cover vision care and dental benefits. Are those benefits that are provided through that plan, or are they separate benefits that are negotiated separately?
Yeah, the New York State Health Insurance Plan in total has a number of different options, both medical options, and then it has some ancillary benefits, vision, dental, some other things available under it. Not all employers participate in all of them. I was just simply referring to just the medical plan versus this medical plan that does have other components available. And again, that's something that some districts do provide. It's not part of the consortium. Some districts do provide dental vision outside. Some have flex spending accounts. Some have other programs. Those are all outside the consortium. The consortium only deals with just the medical plan.
But do you know in the state health plan with the vision and the dental benefits, for example, are part of that plan, or are they completely separate?
They are completely separate. It's a separate premium you have to pay for. But it all comes under that umbrella of the New York State Health Insurance offerings, if you will. So it's a separate program, separate premium. Some people elect to do it in terms of employers, some don't. That's a good question.
Is there, between Plan A and Plan B, is there a difference in percentage of what the district pays?
I'm sorry, repeat that?
Between Plan A and Plan B, is there a difference in percentage that the district pays in?
No, again, in terms of the consortium and what they make available to the school districts and what directives there are to the school districts, the only thing the consortium offers is the benefit plan. Here's the two plans we're offering. It's up to the school district to decide who can have the plans and how much you pay for those programs. So in terms of your premium contribution, the amount you pay towards the coverage, how you invest for the coverage in retirement, how much you pay for the coverage in retirement, how long you get to keep the coverage in retirement, those are all local decisions that are made at the district level between the district, the collective bargaining units, and is really dictated by contract. If you're not subject to a collective bargaining agreement, that's board policy or personnel policy, maybe an individual's contract. Other than that, it's typically collective bargaining agreement, and those decisions are all held and maintained at the local level. There's no, actually, it's all over the place in terms of all the different districts and what they charge their members. In terms of premium, there's all different, I don't even know what the different ranges are. And from my understanding in terms of school districts and all the ones that we deal with, the average is probably getting close to 15% now. It used to be 10% a couple of years ago. It's probably starting to bump up a little bit. But again, that's different from district to district. Yes.
Does the Empire plan include vision and dental care?
I'm sorry, repeat that one more time.
Does the Empire plan include vision and dental care?
The Empire plan being the New York State Health Insurance Plan?
Yes.
They have it as an offering. It's an additional premium you have to pay for. And if anybody, I mean, if somebody wants that information from the district, if you request from the district, you can certainly get it to them and provide it to you. Yes.
So, plan being developed for request by districts to reduce.
Yeah, you got to, you know, for years it was only one plan. So now, you know, you fast forward after 20 years or whatever, premium is going up, going up, going up. Several of the districts came to the consortium and said, we need some relief. We need, you know, our budgets are a little strained. We need some relief. We need to have something we can negotiate with our members. Some of them are looking outside the consortium for alternative benefit plans. So instead of having them do that, which we feel in the long run would be more expensive for everyone, we said, well, why don't we bring it in-house, we'll study it, we'll come up with an alternative plan or plans that people would have available to them for negotiation, and that was kind of the genesis behind this. They wanted to keep the number of plan designs fairly limited, because from a management perspective, obviously it's easier if you have less plan designs out there, from premium equivalent rate development, from budgeting, from administration, from the blues, etc. It's just an easier process in the long run. Will we come up with other alternative plan designs in the future? Possibly. But as of right now, this is all we were charged with. This was developed several years ago. Several districts have it. I think the first one in was Ticonderoga. Most districts still are with the old plan. And we're, again, it's a conversation. People are looking at it. Times are changing. Obviously, everybody's feeling financial strain from employees and retirees to schools. And it's just a tool that people can use, again, for collective bargaining purposes.
What do you calculate district savings on that? All of this will increase the cost of Plan A, Plan A. What do you calculate it to?
It's right on the sheet. The difference between the two premiums is what the district said. It varies from district to district. I mean, it depends on the number of contracts. I didn't do the math. I don't know how many contracts you even have here. In this. I'm sorry.
That's the only calculation.
Well, I mean, I don't know how many contracts you have in individual family Medicare, but you can certainly do the math. It's just the difference in between the two premiums. For an individual, it's whatever it's sort of $400 a year. For Medicare, it's $1,200. So that's a straight savings in aggregate, and then it depends on how much is the district paying, how much is the employee paying, and how many contracts you have in each.
Kind of more complicated, feel free to chime in. I did some of the basic math. Our consortium offers 2 plans covered by the same insurance provider. Plan B premiums are nearly $1.1 million in savings for our district, Plattsburgh City School District. Based on 95% of that going towards benefit, I've approximated the number of lives covered by our district is about 800, maybe more, maybe slightly less. If one were to take the 95% of 1.1 million divided by 800, that works out to about $1,300 yearly being passed on to each life. That's $4,200 yearly for a family of 3. So based on my calculation, wouldn't that money just be being passed on to us as the insured? Like that cost is what's being passed on to us?
That's just a premium.
Well, we're talking the whole benefit package itself. Now that's on average, right? Now, as you mentioned before, there are many people that don't use their insurance, and this would be a great Plan B, the amended plan. I think would be a great plan to save money for the people that don't use their insurance. But for me personally, when I buy insurance, I don't buy insurance not to use it. I buy insurance for the worst case scenario, in which case, God forbid, I would get diagnosed with cancer, come across some life-threatening illness, in which case the fees are astronomical.
Well, no, again, you've got to separate, when you're talking about cancers and surgeries, those are paid in full in both programs.
On prescription.
Only prescriptions.
On prescription.
Right. You're going to pay $5.
I know members within our association that have upwards of 300 prescriptions a year. And you can't say, and I know that many of those prescriptions are going to be up in the Tier 2 and Tier 3 category. Their cost, and it only takes one member of our association to have this plan go all up the head. If their costs are astronomical, and
I'm only telling you what this are between the 2 plans. We're not getting into scenarios about different cost structures and how it's going to impact people. The only thing I can tell you is this is exactly what the benefit plans are. This is what the cost is. If you want to have that dialogue, that needs to be at the collective bargaining table. It's not what we try. I'm not here to argue with you about the impact to each individual person here and what it's going to be. I'm just here to tell you what the differences are. The only thing I can tell you factually,
Passing on of
no, not in all cases. On average, yes. On all cases, no. And the one thing I will tell you that you're not, weren't accurate on is that the overwhelming majority of drugs will be tier 2 and tier 3. That's not supported by the data. The generic drug rate is 74% of the scripts filled are filled generic. And only...
I'm not talking about getting a cold. I'm talking very small percentage, few. Right? Few individuals. It only takes a couple individuals. Understood. This plan is not better.
Insurance, we all pay a little bit so that nobody gets hurt. But we are looking at Plan B, the 18% savings is going to be distributed unfairly to those that are the sickest. And perhaps a more fair way to actually negotiate, we all just pay a little bit more towards our insurance if we go to Plan B. As much as that might be something we don't want to do. You're going to pay, well, somebody, I'm not going to pay anything, because I'm not, I need medication, you know, tomorrow that could change, right? So, the very sickest people, the people with the most need for medications are going to pay the most, and that's defeats the purpose of insurance. Insurance is to spread out that risk, so that everybody pays a little bit, and that's what I think is bothering you. You're seeing that not everybody's going to be treated the same under this insurance plan.
I just want to take a moment to interject. It feels like we're drifting perhaps away from plan design questions, specifically the comments, which is fine, which was always going to happen here, which we've certainly allowed for in the program. And that'll be the next phase, and we'll move to that as soon as we're ready to move to that. But just in case there are technical questions or Plan A, Plan B specific questions for Mr. Locey, I want to make sure we deal with those first, after which point we're going to open the floor very broadly, and then you won't have a chance to comment on that.
Yeah, two questions, and they're sort of related. First off, I'd like to know if it is New York State law or the Affordable Care Act that has caused a dropping of the copay on cancer drugs. And in your estimation, just so that we know what's going to happen in a year or so, what effect are we going to have? What effect are we going to feel with the Affordable Care Act and the way it's changing the insurance bill?
I do not know what you're referring to in terms of the chemo drugs.
Copay has been dropped.
I don't know the specifics to that. I'd have to look that up. I'm sorry. But in terms of the Affordable Care Act impact, we've already seen a lot of it in terms of benefit change. I can tell you that as part of the budget for the 2013-14 fiscal year for the Consortium, we built in 2 additional costs that we've never had before, directly related to the Affordable Care Act. One is Affordable Care Act. They refer to them as insurance fees. I refer to them as premium taxes, which are going to account for about 2.5% of total premium in a given year. And the second one is what they refer to as a transitional reinsurance fee. Again, they call it a tax, which equates to about $5.75 per contract per month that the consortium is going to have to pay out that we've never had to pay before. They start January 1st of 2014. The transitional reinsurance fee has to be paid by November 15th of next year. The insurance fees or the premium taxes, we have to start paying those effective January 1. So for next year, we built in about a 6-month impact. The 6-month impact that we built in was somewhere between 1 3/4 and 2% increase in expense that we had to have. This new expense we never had before. Going forward, it's going to be double that. So it's certainly going to have some impact on cost, and unfortunately, that's going to be felt by everybody. That's a straight cost. It doesn't go to benefit. It doesn't go to making the program any better. That's just a straight added-on cost that we're all going to share in as a result of that. In terms of specifics about the chemo drugs, I'm sorry, I don't know that off the top of my head. I haven't been back on that. Yes.
Is there a way to find out personal impact for each individual?
Yeah, and basically what you would do, what I would do, if I was sitting in your seat, you've heard the differences between the two programs, go back and look at your bills. Look at your explanation of benefits from Blue Cross Blue Shield. You know, the types of medications you're on, how many times you went for office visits, how many times did you satisfy your deductible? If you did, how much, 20% did you pay? How much did you pay in 20% for drugs? $8 co-pays for mail order? What types of medications are you on? Look at that. And then I would also have a conversation with my physician about medications, if I'm on a number of them, to see if there's alternatives that I could be on, whether it's going from a brand name drug to generic, or from a non-preferred brand to a preferred brand. And then evaluate that, and that's going to tell you what your individual impact is. Certainly to try to give you the impact of all the people here tonight would be impossible. Because again, every single person is different. I could probably pick out, most people all fall in similar categories as me, borderline high blood pressure, high cholesterol, don't eat right, don't get enough exercise, so you're on a couple drugs. But then there's people on both sides of the equation who fall outside that. So to try to give you samples and examples, it's really not going to be meaningful. The only thing I can suggest to you is to go back and research your own expenses. For those of you on Medicare, you know, the deductible, the co-insurance amounts, the deductible is going to be more meaningful. The co-insurance, the out-of-pocket maximum is going to be less meaningful. The prescription drug copay is something you're going to want to key on because Medicare is taking care of the lion's share of medical expense. So focus on the prescription drug. For the regular employee, the early retiree, if you will, too, look at all your expenses, both office visits and prescription drugs, and try to figure out the impact.
You know, you mentioned this, you go back and look at the law. But the fact of the matter remains that if we look at these, tier 1, tier 2, tier 3, tier 3 are patented medicines, the ones that the drug companies have spent a fortune on. Those are locked in. So if you want to go back and take an old medicine that's out of the complaint of where they can fall, you can do that. Every one of these tier 3s are the latest medicines that are out there, and you got it. That's the one you want. You don't want a tier 1.
The only thing I can give you is statistics. And what the statistics tell us is that in terms of tier 3 utilization, 15% of the prescriptions filled fall into that. That's all I can tell you. In terms of what everybody will be on, again, we're not getting into conjecture. We're not going to get into a debate over what drugs everybody's on. All I can give you is the statistics. 74% of the drugs are filled generically.
Let me answer this for one point.
Sure.
We had a benefits person at one time. He came in and read a whole list of medications that he claimed that the employees were misusing the system and taking the most expensive drugs. I couldn't answer the question. I couldn't ask the question at that time. I had no idea. Unfortunately, I have a nephew who works for one of the major pharmaceutical companies. He's a pharmacist and a doctor. Besides, he has a doctorate of pharmacy, a doctorate in medication and medicine. And I went to him and I gave him the list. And I said, can you go through this list and tell me if there's anything on that list that is cheaper? And he looked through the list and he said, every one of them are patented. Until the patents run out, that's what's going to pay, because those drug companies spend a fortune. Now, that's what we're talking about. If you want the cutting edge of treatment, you pay. Because they control it. They spend millions of dollars on it. Just do the research. And then they have to go all the tests. So what are you going to get? You're looking at $30 for any piece of prescription that you can get.
Well, that's just not factually accurate, but well, that's not accurate.
And didn't you just say that if that's, well, we're not getting into the weeds, but you might start us on the low generic drug and then only through several trials?
There's a limited number of drugs on the step therapy list.
How do you get that list of which ones you have to go through that step?
The list is available, that's correct. It's also available on the Blue Cross Blue Shield website. You can go on there and take a look at it. It's a limited number of drugs, it's not every drug, certainly not nearly every drug.
Good. Any other questions specific to plan design, please?
If it's a 10% contribution, I just did the math, real rough, but roughly, per year, for an individual, it's 150 less. If you're 10%, if you're contributing 10% of the premium, 150 less for a family, about 400, and for a Medicare person, about 120. Yes. And you can do the math. I mean, it's just the difference between the annual cost of the two programs is roughly $4,000. 10% of that would be more.
Just a quick question. Did Excellus design this program, or did someone else design this program?
We designed the program along with the board of directors.
Locey?
Locey and Cahill, along with the board of directors, designed the program for the board. Blue Cross Blue Shield obviously has to have this available. It has to be a filed and approved contract, which it is. It's certainly on their list of options that they make available to all employers. So I mean, it's not like we just made this up out of thin air. It's just a benefit plan that's pretty common out in the marketplace. And we presented that to the group. Yes. Yes. Correct. And then the consortium board of directors evaluates that and approves it, and then the ones that ultimately, I guess, designed it in the end, or approved it in the end. Is there a question on there? Yes.
A comment, first of all, and that is that I think you have to be very careful when you're talking about how much difference would it make between planning and plan B, because none of us has a crystal ball. Nobody knows sitting here today what your medical conditions are today versus next week. And I think we have to all be very careful about that. And I think Tim was trying to allude to that to a certain extent. And that is that even if there's one or two of us covered under the association plan, if we have a serious condition and all of a sudden these prescription costs and co-pays become a very, very serious situation to any individual. And it could be you or it could be me. We don't know. That's where we run into a major problem. A question I have is, how long has Plan B been in existence? And how many of our consortium districts are under Plan B?
Plan B has been in existence, I believe, since 2007. And I believe we have about 15% of the population in the program.
Okay, translate that for me. How many districts are in the consortium?
16 school districts in Locey.
16 school districts plus Locey. And how many of those? I want a percentage.
I don't know off the top of my head.
In Plan B?
I don't know off the top of my head.
Well, you mentioned ties.
I know ties because all their employees are in it. Some districts offer it as an option, and I just don't know the count on that. I know it's about 15% of the total population.
15 or 50?
15. Yes.
Question on that. I was, you're talking about the chief school officers who are a part of this consortium who asked you to, present this plan, correct?
They asked us to develop an alternative plan that they could offer the collective bargaining table. Yes. That's correct.
My follow-up question to that is, are the chief school officers also accepting Plan B as an option?
I believe in some cases they have, yes. I don't know specifically who. I'm sure you can find out this information if you ask it around. Generally speaking, I know that with a couple of districts, the administrators are in the program and some of the rank parties in Plan B, but I don't know the numbers on that.
I have a question. Not only is it the teachers' unions that are covered by this, but isn't CSEA also under this?
Oh, yeah, all the collective bargaining units, all the non-bargaining, all the retirees.
All the employees of the school district
are under the consortium in one form or another. Correct.
I just have a question about well child care. I don't think there appears to be any difference in the two plans.
There's not.
This says the well child care visits up to the 19th birthday. Has that changed now to students still in college or age 6?
When the state mandate was passed for the well child, it was specifically for children. So there's a state mandate that covers children up to their 19th birthday, And then on the federal side, now everybody gets a routine physical. So even your adult dependents, and they seem to be staying on my plan a lot longer than they used to, up to their 26th birthday now, they can also get a routine physical. It's just not pediatric. It's not covered by the pediatric guidelines. It's just a different level. Things fall into the adults. They're not adults, but they, in some cases they treat them as adults, in some cases they tell them trouble as children. I don't know, I can't figure it out.
Many of us who have achieved what you mentioned getting older, I'm already there. But back in years before, there was a provision that allowed, or most districts honored, that retirees would be not subject to changes in plan. For example, when teachers started to contribute, those of us who had retired previously were not required to contribute. The reason was that our salaries were based upon the negotiations that were done at that time. We gave up contract increases in order to get benefits that would be taken away from us. Now, my question is, if the districts decide to go to Plan D, is there anything that keeps them from allowing retirees to stay on Plan A?
That's a district by district decision and part of the collective bargaining process.
That is a possibility, though. As far as you're concerned, something they could consider.
It's certainly a possibility. It's certainly happened in other cases. It depends on the district and the way they negotiate. The only thing I can tell you is from a statutory perspective, in New York State, there's a law in the books where they can't change the retirees' coverage without making a equivalent change to the actives. There's nothing in the reverse. So from just a factual perspective, it could go either way. It's up to the district and the way that they negotiate the contract and the way that they employ the benefits of the retirees.
Well, I think you mentioned in negotiations, the retirees are lost souls. We're at the mercy of the active teachers only. And somebody has to be able to watch out for the retirees.
From what I know about all the collective bargaining representatives, and they're all very good, they are very well aware of their need, if you will, to keep an eye on the retirees, even though they don't have I guess, a legal direct representation. They know that you're out there, and I'm sure they're going to do everything they can to protect you.
Does the consortium in any way supplement Plan A over Plan B as far as the costs to the district?
We're trying not to. When we first established the program, we did it with a 10% cost differential because we just didn't know what the utilization would be. We certainly don't have what we would deem to be a statistically valid size group in there yet. But we have done a lot of analysis to look at not only this program, but other programs that we consult to, similar benefit packages, to see what the cost differentials are. So we have ratcheted that up a little bit. Based on our recommendation to the board of directors, that differential is probably set down unless we come up with some analysis that shows some dramatic difference in what we're currently looking at. So I don't expect that differential to grow much into the future. In terms of subsidization, I don't know that today. I can tell you that with any insurance plan, the subsidization happens all the time. Whether it's from individuals to families, or families to individuals, Medicare for age people to others. That's basically the whole idea behind health insurance. In terms of the way that the two plans are rated, we don't rate the two plans based on solely experience. What we try to do is look at the benefit difference based on the average person and come up with a premium difference based on that. And the reason you do that is because if you do it solely based on experience for just a segment of the population, and it's a smaller segment, if you have one significant loss in there, it can really skew the data. So when we look at the increase from year to year in terms of the overall budget, we're looking at the plan as a whole. And then the only difference we're applying to the two rates is the difference between the benefit. Going forward, you should see both plans step in terms of increase at roughly the same level going forward. Because I think we've got the differential now where it should be in terms of the benefit difference. Yes.
I have two questions. Your prescription tiers, who determines which prescriptions are which tier? That's my first question.
Okay.
And following that
itself, Blue Cross Blue Shield's formulary. It's the same formulary that they use for all their insured population. They do have a, what they call a pharmaceutical therapeutics committee that looks at these. It's made up of pharmacists and physicians. They look at the different medications that are available based on the different disease classes, and then they tier them out based on that structure, tier 1, 2, 3. Do drugs change from tier to tier? Yes, it happens all the time. Typically, on about a quarterly basis, Blue Cross Blue Shield will issue their new formulary listing. If you go online, it's updated constantly. But the written document, which is printed out, is typically updated on a quarterly basis. They also provide, around that same time, a list of medications that are either being newly added to their new therapies on the market, or ones that are changing tier. Typically, when drugs change tier, it's a result of something else happening in the market. The most common is if you have a brand name drug and a generic becomes available for that particular brand name drug, it'll shift tiers. But it does commonly happen as you move from tier 2, tier 3, tier 2. It's not a lot of drugs on a regular basis, but it certainly does happen in terms of a frequency. It happens on a pretty regular basis.
I'm going to interject at this point. I've sensed a desire to move on to the comment and opinion portion of tonight's program. I fear that we could go on, given Mr. Locey's knowledge and the many questions about this topic for hours. I'm certain he'd be willing to return. I'd ask that if you have questions specific to the plan and plan design, that you forward them to the district. If there's a sufficient number of requests, we'll certainly attempt to bring him back or seek answers through him. But there's another important part of tonight's program, so I don't want to shortchange that phase. The design was to allow for, and by the way,